Great points. All right, are we about probably like 5-minute mark? One more. Another question from the audience or statement, comment? Everybody's afraid to speak because they're afraid they're going to get the ding dong. All right, well, we'll move to the second question. So that second question, and Rick, we're going to start with you on that. How can requiring a topic in accreditation be linked with improved quality?
Well, I think linking to improve quality, I'd almost reverse that. I'd say the process needs to start, in order not to be hoist by my own petard, with the patient, the public trust. From there, you work backwards then in terms of, so if the public needs X, then what do we need to do, and what are the knowledge and skill bases that are necessary in order to get to X? And from there, you go back to then the educational mission and say, what do the educational institutions have to do in order to get to the knowledge and skills that get to the X that the public needs and that the society needs? And you can see where this would go all the way back. And so I think if we always use the public as our benchmark, as I said, and work backwards on that, the linkage becomes obvious. The accreditors are there in terms of defining then, are you really doing what you say you're doing in trying to meet the public good? The interesting part to me now is trying to link, though, more between the licensure boards, which really are the enforcement arm of our accreditation in public protection, the accrediting bodies and the certifying bodies. And I think we do not have the needed collaboration and consistency across that licensure board. In fact, licensure boards ends up that are the major controllers of continuing education because of those requirements are there. Most accrediting bodies say don't deal with the continuing education issue because the education process is over as far as they're concerned, except for the lifelong learning. And so licensure boards have had to adopt and include within their license requirements the specific requirements for continuing ed.
Thank you, Rick. And he was trying to outline some of those components that were necessary. If you look at the question, I paraphrased it a little differently, but the second question was, what are important components to impact the quality of health professions and education in healthcare? So Rick, or Peter.
So I think one important aspect here is there has to be a compelling reason to do this. And I think the IOM was probably 40 years early in identifying the fact that a change needed to be occurring and that it had to be more interprofessional in nature. Now, what's changed, the changing healthcare finance system, I think, is the biggest driver right now that's creating the urgent need to figure this out and do it better. I think it all boils down to getting all the stakeholders together to have good communication among them, to foster collaboration. Somewhere along the line, there has to be some measurement and assessment of, what do we want to accomplish and how are we going to know if we get there. I will caution, however, that in the assessment game, the perfect is clearly the enemy of the good. Too many times we're waiting for the perfect instrument and then, a year goes by and we haven't done anything. And sometimes simple things can mean a lot. I also think that in doing this, there has to be incentives for the people, the faculty that are doing this. It can't be an add-on and a freebie. It has to be top-down. It has to be looked at in terms of their promotion and tenure requirements, how money gets split up, how their percent effort is addressed. Otherwise, it is a system about to fail, because unless it's addressed at that level, it won't continue.
Thank you. Judy?
Yes, and in addressing the necessary components of the system, I am struck by the silo picture that we saw earlier this morning where they really do stand side by side without connections. So I think, again, really fully embracing the notion that this is a system of three interrelated components, the education component and practice, and how does accreditation work to bring all of that together. So whatever it would take to put that into play and make that more overt in all of our conversations and discussions, I think would really be an important piece. And I know yesterday when Susan put up her diagram and described where, what is the sweet point for accreditation and implementation and where should that be, that really resonated with everybody that was in that room. And so if I had to urge further conversation in the system, it would be around that piece, which is getting us back to implementation, which is what we've said is where we really need to be taking this conversation. Next is to the implementation phase, and that's where the devil's in the details. But what does that look like? And that's probably where the payoff in our energies are going to be, focusing on that.
Thank you. You're also good staying within that 2-minute mark. So now we're going to go out to the participants. Pat?
Well, I think we had an example of a topic that did change, and that was the IOM report with quality safety. It did change a lot, and particularly the IHI's never events, those changed. And I think this conference, we have had two topics. The social determinants of health, and not just what they are, but what do we change our curriculum to do about it, is one. And the second one today was One Health. With the dangers that we're living with our food and epigenetics and how it changes everything in addition to we have it. It's just a matter, if we put those topics into the pot, then it will change curriculum and cause change.
Thank you for those comments. Others? David?
So I'm struck, and it kind of links to Pat's comment as well. I'm struck by the fact that the questions have focused on health care rather than well-being or One Health, and I guess One Health sits between well-being and health care. Could you reflect on if by reframing that would make any difference to the way that we go about looking at this issue of core competence?
I heard somebody the other day say it's not health care, it's health and care. And I know our standards have been written in a way that we look at prevention and coaching of people in chronic disease management as much as we do, inpatient care, and we have specific rotations in each of those areas with, requirements that people have exposure to things that are more in the wellness arena, and then others in the more secondary and tertiary care arena. So, so the issue is trying to position people to be able to do that. Some of that is going to require, I think, over time, even more dependence on digital communication, because I think real wellness is going to come from the silos are distance apart. They're not next to each other, and they're not rounding capable. So the issue is, how do we teach people to do this electronically together and to trust each other and to get those outcomes that we all want?
And I would just add to that, just in reflecting upon what a shift from the healthcare emphasis to well-being is, what would that mean for our curricula? And as I sit here and I, just kind of reflect, it's not that these concepts aren't in there, but that's not the predominant focus at all. It's more on the healthcare. So that would really be a real shift in how we prepare our graduates, I believe, in terms of looking at our curriculum and redesigning it somewhat to meet that goal.
Just have a comment as well with that. Yesterday at our table, we were asking to define excellence in education. And immediately we said quality health care. It's just something I think we use. This is part of the culture and what we say. I think there's going to have to be a whole culture shift, going back to the One Health and wellness, health promotion, and as you said, changing the curricula for all professions. Comment? And then Mary Beth.
Yeah, this is on the language thing, and I've been working at it. I spend a decent amount of time as a writer, but to actually, we use this term healthcare, and everybody knows we have a disease management system. And often, actually, our focus is not even on the best disease management, it's on production of services. And that's kind of the core industrial driver. And so there's medical industry, there's sick care, which is very, very, very important, right? And then there's health care. And I really urge all of us to think about, are you really focusing on the reactivity to the disease to kind of get somebody back to okay? Or are you focusing on health care, which is different, and start to actually pull back? I think that we have a hard time with health because we throw the word around when that's not what we're talking about. You know, I really urge you to think about, in a moment, are you talking about health care, or are you talking about the way an industry is working and what's good for the industry, or are you talking about managing diseases? Because they're different things, and I think we diminish and kind of mystify our, get in the way of our attempts to move towards health by using it for these other things.
Great points. Mary Beth?
So I really like this question, particularly the first part, because I think it is something we haven't thought about. We talk about education, practice, and accreditation being a system, but we actually haven't defined what that is. And if you look at each of them individually, they have different missions, they have different values, and to even put this together, I think there has to be some thought around what is this and what should it look like? I think we're sort of jumping to what should it do before we even know what it should look like. And I like in the system, because I don't think we've thought about this as its own system, what defining that.
Thank you. Yeah, I'm going to take one more. One more. Sorry, I'm breaking the system.
Great. I think that one other component that we need to consider is really looking at how we're talking about prevention of care and what are the entities and elements that people are going to be engaged in. What are the activities that we'll be engaged in? Currently, the healthcare system in the United States is a fee-for-service model that pays us to treat a problem, to assess and treat a problem. It does not pay us to prevent problems. It does not pay us to engage in healthy behaviors, even though there are some activities that certainly are being promoted now to really help us see that. But truly, the money is still at the disease end. And until the money is really more overarching and includes healthy living, I don't think we're going to see the kinds of changes that we want, not to stop us from considering these components that are necessary relative to practice and education.
Thank you. Sounds like you're adding some more necessary components in the system than just education, practice, and accreditation. I totally agree. Okay.